Mr. X, a 30-year-old male whose advocate from Bihar, presented to our OPD who had come here for evaluation of primary infertility. So, on further probing, he had complaints of some increased weight gain for the past 5 kgs for the past 3 months. He also had complaints of some generalized lethargy. There's no history of any headache, no blurring vision, fractures, any renal calculi, or increase in size of hands and feet. So, past history wise, he was recently diagnosed to have hypothyroidism, for which he was on thyroxine supplementation. Outside, he was diagnosed to have some hypogonadism and was treated with testosterone for 6 months, and he has eventually stopped testosterone owing to the peer pressure. There's no history of any hypertension or any diabetes mellitus. Personal history, was married for 4 years. He had no children. Family history, there was no significant family history. So, on general examination, he was conscious oriented. He had a tall stature. He had his stature was somewhat similar to the photo present in this picture. He was found to have a upper limb. He was found to have a upper limb, lower limb, a height of about 178 centimeter with upper limb, lower limb ratio of 0.9 with an arm span of 171. The general examination showing a micropenis, a bilateral gynecomastia, sparse facial and body hair and testicular volume around 20 ml. On initial presentation, he was vitally stable. No pallor, ictus, cyanosis, clubbing, lymphadenopathy, or edema. Systemic examinations were within normal limits. So on looking into the morphs, we consider it to have we think to be a probable Klinefelter syndrome. So I like to speak today on the causes of Klinefelter syndrome and the management part of it. So basically, when he had initially come, he was found to have he was found to have normal hemoglobin with normal counts and platelets. His TSH was within normal limits. He was found to have low testosterone levels of 29.9, and we had sent LH and FSH, which are still awaited. So coming to our Klinefelter, so it was first Dr. Klinefelter first reported 9 patients who had 9 men who had enlarged breasts, sparse facial and body hair with small testes and inability to produce sperms. These people were found to have an extra X in their chromosome compared to the normal XY genotype. So basically, in the the classical form of Klinefelter syndrome has a 47 XXY karyotype leading to aneuploidy of the sex chromosomes leading to the development of the disease. Normally, the prevalence of Klinefelter syndrome ranges from 3 to 4% among the infertile 3 to 4% and 10 to 12% of the men were azoospermic, and it's the most common frequently abnormal sex chromosomal abnormality that is known to cause infertility. The pathophysiology is the most common cause of Klinefelter syndrome is due to non-disjunction of sex chromosomes at meiosis 1. It's mostly due to 50% of the cases are due to paternal non-disjunction at meiosis 1. And there are many other factors leading to development of chromosome. I like to focus on the extra X chromosome escape inactivation, and the other pathophysiological factors would be FSH polymorphisms, AR receptor, length of CAG repeats, which indicate length of CAG repeats, which indicates androgen responsiveness, and pseudo-autosomes, SOH gene overdose. So I'll be like to focus on extra chromosome and escape inactivation. So normally, the X chromosome gets inactivated during the course of separation. However, 15% of the gene escapes inactivation. In Klinefelter syndrome, the escape inactivation lead to development of that extra X chromosome, which lead to development of the features of Klinefelter morphosis. And the extra X chromosome material is mainly responsible for the testicular hyalinization and fibrosis, which had led to the gonadal failure, which led to eventual development of primary infertility in adolescents and young adults. It usually manifests as newborns as a microphallus, hypospadias, cryptorgasm, or a tiny testis. Evolving hypogonadism lead to incomplete puberty and gynecomastia. Normally, the clinical features of normally clinical features of Klinefelter syndrome are like the known phenotype. We know the most amount of the phenotype. However, there's a large form of the Klinefelter phenotype which has mild symptoms and less likely to be evident, and they will be only be evident at later stages of their life. So the clinical features mainly of Klinefelter syndrome will be normally because of the supranumeric chromosome before puberty, they manifest in the form of congenital malformation, longer legs, small testes, and the symptoms should be speech and language disability. Because of the testosterone deficiencies, they lead to develop this absence of body hair, reduced muscle mass, bilateral gynecomastia, and longer legs. And because of the supranumerary X chromosome, they lead to development of gynecoid hypostasis, tall stature, their increased BMI leading to overweight and reduced bone mineral density in these patients. Testosterone, which is responsible for increased bone mineral density, gets reduced. On seeing infertility is the most common presentation which is seen in Klinefelter syndrome, followed by small testes of less than 6 ml, increased gonadotropins of more than 95, azoospermia of 95, and decreased testosterone levels are also found in these patients. The patients, it's also associated with abdominal obesity in 50% of the cases, osteopenia in 5 to 40%, and type 2 diabetes mellitus also found in half of the percentage of the patients. So these are the mechanisms, these are the multiple mechanisms which lead to the manifestations in Klinefelter syndromes. The hypogonadotrophic hypogonadism, which leads to decreased androgen, decreased estrogen and androgen, leading to increased fat mass and increased lean mass, eventually leading to type 2 diabetes mellitus. The hyalinization of the hyalinization of the seminiferous tubules caused due to the extra X chromosome inactivation leads to azoospermia and infertility, which all the gene mutations can lead to tumors. It can lead to autoimmune diseases. It can lead to cardiovascular manifestations. It can lead to reduced bone mineral, and the gene mutation can lead to reduced bone mineral density. These are the factors which need to be considered. And Klinefelter patients are likely to have less IQ, and they are more prone to develop psychiatric morbidity. So the anthropometry in case of Klinefelter patients, they are usually more taller than their counterparts in the childhood. Normally the arm span is normally our arm span is more than our height. However, arm span more than 5 centimeter from height, a Klinefelter suspicion of a Klinefelter or a Marfan can be made. However, they would have a normal BMI with increased abdominal obesity, increased fat muscle ratio, decreased muscle mass because of loss of testosterone, increased leptin levels. Almost all these symptoms are attributed to testosterone and hypogonadism deficiencies. And the low bone mass, it's due to hypogonadism, low exercise capacity, and muscle strength. So there's a study which is done to compare the normal population along with the Klinefelter population, and it had been shown that the Klinefelter population are taller and have longer legs compared to the controls. They have increased biiliac width, waist size, increased height circumference, and increased total mass, abdominal mass, and total fat percentage compared to the normal counterparts. However, being the testicular volume being reduced. This is the value representation of the same. It has shown that this compared the same thing. So basically, height, weight, and BMI are more in cases of the Klinefelter syndrome compared to the normal counterparts in adults. However, the testicular volume is significant. Normal testicular volume ranges from 40 to the standard deviation 9.5. However, in Klinefelter patient, the testicular volume is 6.5 with plus or minus 4.4. So fertility in case of Klinefelter syndrome. Until late 1990s, Klinefelter syndrome was considered to be cause of total and definitive sterility. However, in the first description in 1998 shown that 2 patients' sperm could be extracted from the testicular tissue and pregnancies have been obtained after ICSC. And the first result has been confirmed in several series with testicular sperm extraction allowing fathering assisted by fertilization technologies. So the evidence of the secondary sexual ratio, which is a indicator of birth, the completion of birth, which high likely in mosaic genotypes of Klinefelter syndrome compared to the classical types of 47X XXY. And the most significant factor which indicates the secondary sexual ratio is age less than. If the patient is a Klinefelter who has been identified yearly has significant chance of detecting have a higher chance of fathering compared to the person who have been detected later on in life. It's and the medications which have been used known to have shown some use now optimal sperm retrieval will be anti-estrogens, aromatase inhibitors, and gonadotropins. So, and the other characteristics and the other problems associated with Klinefelter syndrome, they are most likely to develop cardiovascular manifestations. These patients are more likely to develop ischemic heart disease, mitral valve prolapse, varicose veins, venous ulcers, and deep vein thrombosis. So, there has been a study which has been shown that they have taken 439 patients of Klinefelter syndrome, and it has been shown that as the age increases, the chance of venous thromboembolism has been higher in cases of Klinefelter patients compared to the normal general population, and been 8.6% at 50 years of age and 20% at 70 years of age. Klinefelter syndrome is also known to be associated with multiple autoimmune diseases, and they are more prone associated with Addison's disease, type 1 diabetes, multiple sclerosis, hypothyroidism, which in our case, our patient had rheumatoid arthritis, Sjogren's, and systemic lupus erythematosus. And they are more also prone to develop cancer, which they are having increased chance of breast carcinoma and germ cell tumor. So it's essential that early diagnosis of Klinefelter has to be made to detect, to have high suspicion of Klinefelter has to be made so that they could have a chance of fathering. So in case of birth, the most likely presentation would be a cryptorchidism or a micropenis. In case of childhood or pre-puberty, a reduced testicular size, a tall stature compared to the rest of the population, increased lean, fast body mass, speech and learning difficulties. These are more likely to have a suspicion has to be a suspicion has to be thought in place. And in case of adolescents, reduced testicular growth size, increased fat and lean body proportion, gynecomastia, the suspicion has to be made. And in case of adulthood, chance of infertility, but it's a late diagnosis and it has been fully established, and recovery is very less likely. So in case of, according to Androgen Society guidelines, genetic usually Klinefelter syndrome.
How much more?
3 more. Genetic testing, low testosterone level, they would have elevated FSH, LH, they would have azoospermia, increase LH and FSH. Their bar bodies are found to be 82% positive. They have reduced bone and RBC density. So genetic, the Androgen Society says that the prenatal, the indication for genetic analysis should be prenatal diagnosis of Klinefelter syndrome. Conventional karyotyping of peripheral blood cells can be done to detect Klinefelters, and Klinefelter genetic testing can also be offered to the parents. So this is a summary of the same. So in case of Klinefelter syndrome, at least physical examination needs to be done. In case of on a review basis, physical examination need to be done annually. Mammary and mammary gland ultrasound is also required. Metabolic profile also be monitored yearly. At the first visit, a bone mineral density scan has to be done to look for the strength of the bones. Thromboprophylaxis has to be given in patients who had long-term flights and exposure to other risks. So, as far as the most common, it is the most common disorder associated with fertility, and early diagnosis would definitely have a positive impact in life. So, in our patient, we are planned to start on testosterone therapy after the results. So, we are planned to continue to follow in endocrinology department for further management. Thank you.
Thank you. Rohit, you sent for gene testing for this patient?
No, we haven't sent till now.
So clinically, you made the diagnosis?
With the features of disease and this thing, we made the diagnosis.
Any questions?